This morning, I am excited to welcome and introduce Dr. Loren Denlinger. He is the William W. and Judith H. Bussey Professor in Allergy and Asthma Research at the University of Wisconsin Division of Allergy, Pulmonary, and Critical Care Medicine in the Department of Medicine. He's the department's vice chair for clinical and translational research. He's participated in numerous clinical trials and co-chairs the data monitoring committee at the UW-ICTR. He's medical director for UW Health's Advanced Asthma Care Clinic and holds 2 patents and has research interests in the mechanisms of airway remodeling after asthma exacerbations. He's currently a PI with the NHLBI Severe Asthma Research Program and leads multi-center biomarker-informed platform adaptive clinical trial for patients with severe asthma. Please join me in welcoming him this morning.
Thank you for the introduction and for the invitation. It's really an honor to be here to talk about a topic that I'm really passionate about and excited about. So the target audience for this is really trainees and clinicians. And it's the general message is, even if you're a clinician, great, but you can help with clinical research too and make a huge impact. So when I was a trainee, and I'll advance this to give you my disclosures as well, I had this really high-minded idea what clinical trials were, meaning like a brand new drug versus placebo or brand new device versus placebo. There's also this design in clinical trials called comparative efficacy. And so there's a clinical trial design type called comparative efficacy, where you're really randomizing groups of patients to 2 standard practices that are well established in the field and already approved by the FDA. And so when I was a junior faculty member, I was proud to be part of a clinical trial network called the Asthma Clinical Research Network. And I wanted to highlight one of those trials just as sort of a introduction to show you that comparative efficacy can lead to change in guidelines. So this will be my one asthma slide in the whole talk. And standard practice 10, 15 years ago was to take a patient with newly diagnosed asthma and give them 2 different inhalers and say, okay, this red inhaler, you're supposed to use 2 puffs twice a day, every day, regardless. And the green inhaler you can use whenever you want, and it'll make you feel better. And no matter how well the instructions were put on the labels, patients would go to the pharmacy and they would have sticker shock because both of them are just as expensive. And then they'd go home and they'd try them out, and albuterol works within like 3 minutes and people feel a lot better. And an inhaled steroid, you don't really notice whether it helps. And, over the course of a year, you might have fewer prednisone bursts or trips to the ER, but patients don't really get that. And they remember things like, oh, they told me I could do whatever I wanted with these inhalers, right? And so guess what? Over time, many patients gravitated to using their albuterol and not using their inhaled corticosteroid. And so within this trial network, we wanted to ask the question, what happens if you somehow enforce patients to use their inhaled corticosteroid at the very same time that they're using their albuterol? We didn't have the budget to pay for a combined device, and none of the companies at the time were interested in making one. We did have duct tape, and we literally bound these 2 things together, and that was one of the arms in our trial. So the study was published in 2012. It's a 3-arm comparison trial of strategies to adjust the dose of inhaled corticosteroids in patients who came into the trial already well controlled in terms of their asthma symptoms. And so the 3 arms are really using a physician-guided dose adjustment plan where you come in every 6 weeks and the physician would say, oh, you're doing well, let's dial things down or dial things up if you're doing poorly. The second arm was using an exhaled breath biomarker to use some science to say, your dose needs to go up or down. And the third arm was the duct tape arm, where the instructions were every time you need your albuterol, also turn the inhaler over because they're duct taped together, and use the steroid as well. And so the Kaplan-Meier curve is in the bottom right. And statistically, there's no difference between these groups in terms of the time to treatment failure. Numerically, the duct tape arm is the one on the bottom, and that wins. Yay, duct tape. And if you looked at the exposure to inhaled corticosteroids over the course of a year, the duct tape arm had a 50% lower exposure to drug and 50% lower side effect risk. I was pretty excited about that as a trainee, but many other groups and companies got involved, and now symptom-driven use of inhaled corticosteroids are part of both the US and the global asthma treatment guidelines. And when used in this way, there's a 30% reduction in exacerbations when combined with formoterol, which is both short and long acting. Starts within 3 minutes, but lasts 12 hours. And even when you compare that to 2 puffs twice a day of a formoterol containing combined product. So comparative efficacy can move treatment guidelines, and it's really fun to be a part of that. So I'll be the first to acknowledge that my exposure to the practice of obstetrics is from medical school. And my exposure to the practice of gynecology was maybe, a little bit in my internal medicine residency working with Dr. Sarto at the VA. A little bit. So coming into this audience, I was like, what do? I have to get ready. So I went to the literature just to see where the field is at in terms of clinical trials. And, Medline PubMed is great for this kind of stuff. So on the left are the number of trials that have been published in asthma and COPD. And starting in 1954 and going to 2004. For both of these figures, there's a pandemic effect, so it starts to taper off because of the pandemic impeded a lot of our trials. I would argue for asthma and COPD, we were already starting to reach plateau before the pandemic. And I've kind of felt that as an investigator. It's like all the easy questions have been asked. You look on the right, these are trials in obstetrics and gynecology. So you could critique it and say, well, they got started a little later, but they're starting to take off. And I would also argue that I don't think they've peaked yet. So that's kind of exciting to be in the field. So what are the objectives for this talk? So to outline the value of clinical trials, to explain how to get some basic training and join a team, to illustrate the importance of centralized feasibility assessment for clinical trial review, and to discuss resources that are available for principal investigators. So who benefits from clinical trials? Well, certainly the participants benefit in many ways. They get access to the latest interventions. They have a standardized care that's better than care that changes, especially in hospital patients on Monday morning when the service attendings change. They get disease-specific education, and there's hope. Which is huge in some diseases. So I wanted to highlight this article. This was a meta-analysis of over 180 trials or so, and the details will come up in a minute, where they looked for clinical trials that had a continuous endpoint as their primary outcome. So like a pain score or a blood pressure measurement or something that was a number, not yes or no. Did you die, yes or no? It had to be a number. And then the other requirement to get in this study was that there were 3 arms. There was an intervention arm, there was a placebo arm, and then there was an observation arm, standard of care, observe, do nothing. And so they reviewed 186 trials done in 23 countries, 18 different conditions, over 16,000 patients. And what they found from this meta-analysis is that half of the overall treatment effect was due to placebo and natural history, which is really shocking. So that placebo effect is real in many trials, and it may be that patients benefit from the standardized care that comes along with being part of a trial. So who else benefits? Well, certainly providers benefit. There's a sense of wellness that comes along with being part of a clinical trial, pride and this deep-seated belief that you're doing the best you can for your patients. There's, the compensation that may be a small piece of this, but really it's about wellness. The institution benefits. There's referrals, there's provider recruitment, but there's lots of ways in which the institution benefits from trials. But But I really believe that all patients receiving care at an institution that does trials benefit as well. And I've even adapted the Wisconsin idea to state, I shall not be satisfied until every patient at UW Health has the opportunity to participate in clinical research. We're a long ways from that, but it's a goal. So I used to get up and do this talk and just say that as a soapbox, and I started digging into the literature to see if there was any evidence to back that up. So I have found one paper that suggests that hospitals that participate in clinical trials and are high volume trialists have better outcomes. So this is a big study in the cardiology space with a primary endpoint of mortality after non-STEMIs. So there's 3 groups of hospitals. And the number of patients are at the top 2. So at the far left, there's hospitals that don't have any clinical trials in their mix. The middle group is the group that has clinical trials, but are kind of a low volume provider in terms of the trials that they run. And then the right-hand group is hospitals that have a lot of trials and are big enrollers in these trials. And so the primary endpoint was mortality. And you can see that there's a visual difference there that's also statistically significant for both groups. Here's the really shocking thing about this study. Only 3% of the patients in the high enroller group were actually involved in a clinical trial. So that mortality benefit was across all of those hospital patients for NSTEMIs. So being at a hospital that has a lot of clinical trials has a benefit, even if you're not involved in that study. So where are we as UW? I'm proud to say that in some diseases, asthma maybe, we're on the right, but the institution as a whole is solidly in the middle. And if you compare us to our regional colleagues, we're dead last in terms of volumes of clinical trials as an institution. So there's been a lot of push and effort to move that bar to get us to a better state. It's a really good time to be in clinical trials right now because the university and UW Health have partnered, and it's embedded in the strategic plan for the university. One of the pillars of that plan is to increase the ease of trials, to standardize care, quality control, and to change the culture at UW Health to make sure that clinical trials is just a natural part of routine clinical care. This is a big part of the initiative for East Park. There are clinical trials rooms and spaces that will be at East Park. And so if I'm be very shocked if part of the department is not going to be at East Park, but this is a huge opportunity over there and open later this year, hopefully. And then the other institutional change that's happened is we now have a clinical trial institute. And they've taken over what used to be called the Office of Clinical Trials, and for a short period of time was also branded as the Clinical Research Office. So there's their website, and there's a lot of resources embedded in that for new study teams. How do you want to go about getting some basic training if you haven't done trials before and you want to find out about more? So certainly, it starts with just getting city training. So human subjects protection and good clinical practice. These are online learning modules that you can do. And actually, we've started to make this a requirement for our residents and fellows as, part of boot camp. ICTR has a lot of courses and certificates and degrees. Can kind of mix and match how much you want to do and how much you want to take that. You can even take this to the level of a PhD in clinical trial design if you want to go that far. The Clinical Trial Institute is developing operations learning modules. I don't know the timeline for that. Certainly, ask your division chief or your department chair, what's going on in our department for clinical trials? How can I help? And, there may be study teams, there may not be, but think about, grouping together and forming a study team. So what do I mean by that? So we have a lot of experience with this in the allergy and asthma research group. So we have a faculty physician and fellow physician study call pool So every half day, a different person is on call. And that means the coordinators can enroll a participant and they don't have to worry about my calendar. Like if I'm on service or if I'm teaching or if I'm, traveling, they can still enroll into my study because they can call whoever is on call for studies that day. And we're all on each other's protocols. And guess what? The coordinators love it because it really helps, efficiency. And from a trainee point of view, the fellows get exposed to lots of different trials. And there's a teaching conference that goes into that. And they get to learn about clinical trial methods. It should be embedded as part of service recognition. So that's something to work on from an administrative perspective. But there's lots of other examples of teams that do this well. So there's an ICU studies team. There was a hospitalist COVID trial studies team, and the Cancer Center does this really well too. So I'd encourage you to think about that as a group. It shouldn't be one PI and one study team. It should be multiple PIs sharing a resource of coordinators and shared study call physicians. So I would argue that federal sponsored trial networks are really, really awesome places to learn how to be a clinical trialist. They're few and far between, certainly, but you get access to protocol design, that process from the ground up. There's centralized training for the coordinators. There's all kinds of ancillary study opportunities for career advancement. Certainly that feeds into training plans for K-23. Makes it really easy to write that. And there may be, local opportunities for that as well. And Dr. Hoppy is a great example. She was the site PI for the chronic hypertension and pregnancy trial that you guys probably know about. And this may be old news for this group too, but this trial won the Trial of the Year award in 2022 nationwide, which was really, really awesome. So what if you're a clinician and you don't have the time to get into, learning about being a PI? That's great. We need that too. But you can help with clinical trials and help about referrals to studies that are ongoing. So, part of the divisional updates, in your monthly or quarterly meetings should be, what's going on in terms of new trial opportunities, so that people know about what's going on. And then as an individual provider, acknowledging the value of those trials, because you may get asked by your patients, I've heard about trial X. Do you know anything about that? And you might not know the details, but just having said, I haven't heard about that one, but UW as an institution values trials. And I think, it's an important part of high quality care. That statement alone has huge impact on the patient's willingness to even think about it. And then you can do what I call a warm handoff to the study team, and they can be the ones to do the details of the consent. Coordinators are actually much better at doing consents than physicians because they know the details and they don't have a treatment relationship. So patients are more likely to ask, those tough, burning questions that they might be embarrassed to ask their doctor. How else do you find out about clinical trials? Well, so UW Health has a finding tool. It's a little clunky and not super well utilized, but it does work. And I actually found one of the trials in this department, Dr. Adams' study about glucose monitoring in pregnancy. So the finder does work. So, what are the factors that drive participants into clinical trials? And this is another opportunity for me to go to the literature and think about women's health. And so this was a survey that came out just before the pandemic, a few years before the pandemic, involving OB-GYN departments. It's 4 institutions and 6 different regions, 4 institutions, over 3,000 patients. And it was just a survey to figure out why women signed up for trials in OB-GYN and what were the barriers. And the number one is on the far right that might be getting cut off by the Zooms. So how well the research study is explained to me is the number one driving factor. What we all sort of, think about is altruism. That's number 2. My participation won't help me, but it might help someone else, in my daughter or my, kids in the future. Number 3 and 4 are really interesting. So the doctor's reputation in the community, so my doctor's reputation in the community, and my relationship with my doctor. So whether or not that person is involved in the trial, but just that warm handoff. I know the trial has value. Think about getting involved. Huge influence. I'm not showing you the similar graph about the barriers. The number one barrier to participating or a reason why women did not sign up is if the risks were not explained very well, or if the risks were uncertain, especially in obstetrics, which totally makes sense. So how do you get better about doing those warm handoffs as a clinician? So I'll walk you through this. This is a communication tool developed by Toby Campbell, who's one of the oncologists in our department, who's really, his career is around, communication skills, not only in trials, but also in palliative care. And so the link on the slide there is to a video that you can watch from the med school library. And the intent of this is when you do this with a patient, it's meant to be done in the exam room, in the clinic space. And you literally write out something like this on a piece of paper that they can take home with. So it takes a little bit of prep, but it's hugely impactful. And on the next slide, it goes into a little bit more detail, and I'll walk you through that. So there's 3 sections to this, take-home piece of paper. The far left, what's wrong? So it's the news. Your cancer's back. It's not responding. Talk about that, and you allow that to sink in. The middle section is what can we do about that? What are the options? And the far right is how well does that work? What are the chances of reaching our goal? So being as explicit about each of those is important. So naming it, so what's wrong? In this case, it's incurable pancreatic cancer. What are the treatment options? So, certainly do nothing is palliative care. What does that mean? You get to spend more time at home, quality of life. Standard of care chemotherapy is another option. Name it. What is that involved with in terms of the treatments? And a clinical trial. Name it. What does that involve? What are the treatments? Things like that. And then how well does that work? And you can see the chances or just the estimated odds of that working. And the uncertainty, with the question marks there. So after some practice, you can do this in about 5 minutes. And it's not meant to have the patient sign up to the trial now. They may have sense of what they want to do already coming into this. And if they say that, great, you honor whichever direction they want and you go with it. But the power is that piece of paper that they can take home with them and talk about it with their family. And maybe the next time you interact with them, they'll have a better sense of what they want to do. And a follow-up referral to a research coordinator is hugely impactful. Again, it works best in conditions where you're running out of options. Certainly the example here is cancer. I have used it in my severe asthma trials, and I can say that it worked for me. So the next objective is to illustrate the importance of centralized feasibility assessment in terms of what trials do you want to take on as a group or as an individual investigator. So, if you examine kind of the life cycle of a trial, there's the opportunity. So you might get, contacted by a drug company or a device company to say, hey, think about our trial. And then you have to go through what's called a feasibility review. Can you actually do that? Do you have the patients available? Do you have the time? Do you have the staff? What ancillary resources do you need? Then there's a contracting and budgetary piece that goes through, and then you have to go through the regulatory steps with the IRB and things like that. There's activating the protocol, and that's actually quite complicated. Sometimes there's forms, there's database, there's clinical trials management software, there's internal institutional resource planning, You know, with an industry trial, they'll bring that to you. You don't have to do that yourself, which makes it easy. And then there's actually, you know, executing the trial, you know, getting the patients in and putting them through the visits and accruing your sample size and goals. So how does that look at our institution? You know, so protocol activation is kind of a bottleneck right now. So we get lots of opportunities. We're perhaps getting better as an institution about feasibility review. The slow part tends to be, you know, startup, and the really slow part is the resource assessment. But once we, you know, get through that you know, bottleneck, so to speak, getting studies done is a little easier. So coordinated reviews to really be smart about what studies you pick are important. And then the faster you can get your study, you know, fully enrolled, the faster you can think about the next opportunity. Because they'll, you know, once you get started in this, you'll have more opportunities than you have bandwidth. The institution is headed towards becoming accredited for clinical trials. That's not my goal. That's an institutional goal and championed by the Clinical Trials Institute with Betsy Nugent and Nassia Safdar. You know, to do that and get ready for that, the institution has gone through a lot of prep work for that. So there's now standardized training for research coordinators. There's a lot of process readiness to get the launch times for trials, you know, faster. The UW IRB has gone through an efficiency process to make that faster. We have been known for many years to be a very slow IRB. Actually, I think Merit IRB is a lot faster than UW. There have been updates to the clinical trial management software that have been huge and will enable the use of MyChart and things like that for recruitment, as well as study communications. And there's been a lot of investment in resources, both at coordinator and the pharmacy level. So historically, that feasibility review has been done at the department level. So your chair would have to sign off on each trial that you do. There's now a UW Health Research Operations Committee that is operational. I'm one of the reviewers on that committee. And at least at UW, it's becoming a requirement before you submit your protocol to the IRB. It's not meant to be a roadblock. It's meant to expedite and facilitate critical resource conversations. This trial is going to be done in the hospital, which nursing pools and which ancillary services are going to be involved. Is the lab going to be involved? Getting all of those folks together at the same table is the role of this committee, just to say, can we do this? Can we not do it? Will it be tough? Will it be easy? How can we help them with recruitment? So that hopefully will be in advance for all groups and all studies. ACRE is a accreditation body for clinical research, and I've heard that our timeline to apply for accreditation is coming soon. And that's having that accreditation will help us stand up as an institution if we, for example, we get audited by the FDA for, you know, a trial that goes sour for whatever reason. So lots of resources if you're thinking about becoming a principal investigator. So I mentioned ICTR already. So they certainly have individualized career development, lots of workshops, courses, degrees. They now have protocol writing training sessions. And Leanne Morotek, listed at the bottom, is the contact person for that. They put on community of practice seminar series that maybe you've received in your emails. And they're a great resource for faculty who want to learn how to become an independent investigator and write grants and try to get external funding from federal sponsors. So, and certainly the institution is part of lots of trial networks and resources. that get requests for multi-center studies. So if you just put your name out there to these groups, they might forward you, the next time they get a trial opportunity in your interest, area. And then other key contacts are listed at the bottom. Teresa Linz is more on the data management side, and also the multi-site network, like the Winter Network side. And then Leanne Morotek helps with protocol development. Each department has a clinical department has a vice chair for clinical research. In my department, that's me. So that's the bullet point there on this list. And I know that your department, Kelly Bauman, is that person. Certainly Dr. Bhagavath and Dr. Savecki have some experience with industry-sponsored trials. I got a chance to see the Badger Bite talk that happened this past summer, which was pretty cool. But these next two slides kind of compare, contrast, the things that happen and the resources that you might use for industry-sponsored trials versus federal trials and investigator-initiated trials. So I'd make the argument that industry trials are probably the second best way to learn about running a trial. The companies have a motivation, to get the trial done efficiently. So they're going to come to you with all the tools, and all you really need to do is enroll the patients and follow their instructions. They will really try to make it as easy as possible for it. If you think about that life cycle of the trial, the phases of the trial are on the left here. So there's site activation and selection, there's protocol activation, launching the recruitment plan, completing the visits and invoicing, and then close out. And the tempo for a lot of these phases for industry studies can be really fast. They'll, send you the email, are you interested? Are you interested? And they'll kind of pressure you to sign up. And so that's where having Kelly, to navigate this for you, especially in the contracting phase, is really important. And I should also shout out, I think she mentioned this in her talk, these agreements require a confidentiality signature, and we as individual PIs are not allowed to sign that. It's an institutional signature. So refer that to Kelly, and she can get that process rolling. Lots of resources at the Clinical Trial Institute for industry-sponsored trials. In fact, that's where they actually perform the best. So they can help with budgeting. They can help with research coordination, especially if you want to do a trial at East Park. I think they'll be really well set up for this. So what about, the contrast might be investigator-initiated trials. So that means, the idea is coming from you, and the hustle to get the funding is coming from you or from your department. And I would argue, if you haven't done trials before, it's probably the most difficult space to learn about trials. Because there's a lot of roadblocks and a lot of, long timelines and inherent frustration. So it can be done. But just be cautious for trainees and junior faculty. So the grant and protocol development phase is very slow and often requires multiple rounds of investigation. Make sure you attend to protocol activation, because that can be you might think great, you've got the grant, you've got the money, the IRB, you're ready to go, but if you haven't taking care of the database or the forums or the things like that, and they're like, oh yeah, trial's not ready. You can't start, even though you've got the money and the timeline. I've got another slide about recruitment plans, and then the visit completion is similar to an industry trial. It's really dependent on the clinician and the study team to get the patients in the door. The Clinical Trial Institute really isn't that well set up for investigator-initiated studies. They will do them, but it's not what they're efficient at. And so ICTR is getting into this space, and that's where the training resources are listed here on the right. So the protocol development team led by Leanne, and getting tapped in with a multi-site research network for Teresa. but it's really more of an activity that's best done locally at the division level or the department level with a shared coordinator group if you have one. So what about building an effective recruitment plan? Recruitment for studies is a really humbling experience because you think, when you're launching into a study, a new trial, oh yeah, I see all these patients all the time. They're widely available and they'll, it'd be very easy to get them into this trial. And then you actually try and you're busy. Clinic is a hectic place and it, unless you have a plan or a support person embedded in clinic with you, it's hard to remember to do that. So, when you're building a recruitment plan for your study, think about what's the expected pace of the accrual. So how many sites are involved in this trial? How many patients are expected of us as a site? How much time from start to close, and how many patients do you need to enroll each month to keep up with that pace? Who are the stakeholders for the trial? Do you need to think about community engagement to help with your recruitment plan? ICTR has resource teams to help with this. Has diversity been accounted for? And again, ICTR has a great resource team to help with that. What's the anticipated ratio of numbers of patients you need to screen in order to randomize one? A rule of thumb in the asthma space is about 4 to 5. Some of these more complicated hospital-based studies, you might be screening 10, 20, 30 to get one. Yeah, and so depends on the patient population in terms of the complexity of the protocol. Can you use the electronic medical record to your benefit? And this is an incredibly powerful tool. And the example that I can give is, I'm telling stories here. I've got to keep an eye on the time. So the precision medicine asthma trial that I've been running is a very complex study entry criteria. We worked with the CURDS team, so the Clinical Research Data Management Service. And our coordinators shared the entry criteria for our trial. They built, electronic code to find patients across UW Health that might fit our eligibility criteria. And every month they would send us a list of, 100 to 150 patients who might fit these criteria. We took that list and we sent them just a regular old IRB approved letter with a little bit of information about the trial and a QR code to our website. That snail mail letter was the #1 most effective recruitment tool in the entire network. It might be a feature of Madison, and it might be a post-pandemic feature where people who live in the Madison area actually open their snail mail. The folks on the coast were like, this would never work in Boston or New York or whatever. But it works in Madison. It was really cool. And I wouldn't have thought about it had it not been, actually for the UW Health marketing team was the one who suggested it to us, but also the advances of HealthLink and our ability to use MyChart now for a recruiting system. So ICTR is really, ramping up in terms of, talking about ways to help teams recruit, and they hosted a workshop for that in February. I suspect it'll come back this year at some point. The Clinical and Health Informatics Institute, or Chi-Squared, is embedded within ICTR, and they have the clinical research data service that I was mentioning about. And shout out to the UW Health marketing team. So spending some time to think about your recruitment plan is really important, though, to help make sure that you're reaching your team goals. To summarize then, I firmly believe, and I showed a little bit of evidence, that the availability of clinical trials improves clinical care, even for patients who are not involved in the trial, especially if you're at a high enrolling institution. Teamwork is always better than solo work. It's important to review these trial opportunities together as a group to hopefully enhance efficiency and minimize competition within your own department, or competition for resources like pharmacy or other institutional resources. And then there's a lot of help out there. I think the broad summary for individuals who are thinking about being a principal investigator, if you want help with grant or protocol development, go to ICTR. If you want help with running the trial that's ready to go, think about the Clinical Trial Institute. And with that, I thank you for your attention. I'll take questions and we might be able to adjourn a little early.
Oh, I'm sorry. Are you saying I don't talk loud enough? So when you're talking about getting on a team, are you talking about getting on a team within your division or a team that's running trials throughout the hospital that's, da, 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 da?
Yeah, I mean, I think it's more of an encouragement for trialists who are working in the same space to partner up. So it's not the mindset of one PI and 2 or 3 coordinators as one study team, and then another PI in the same clinical space and another set of coordinators in different study teams. PIs should get together. If they're practicing in the same clinical space, PIs should get together and think about hiring coordinators as a shared resource. Or the other example I gave was sharing study physician call. So if there are, more than one PI involved, think about buddying up to help with the physician oversight of the trial. So physical exams that often come on the randomization day or during the screening process have to be done by a physician. In some trials, they'll let you use a nurse practitioner or an APP. But if you don't have a partner, then enrollment is really slowed down by the PI's calendar. For example, if I'm here lecturing, I can't be doing a physical exam to get my trial patient enrolled in my trial. But if I have a team and I know there's a study call person on, my coordinators can get folks through the door. So I don't know if there's a team, in your department or your division, but maybe there are examples.
Hi, this is Heidi Jansen. I wanted to mention, we do have teams in our department, and we have a human subjects office. So if anyone is interested in doing a new clinical trial, their first step is really to contact Kelly Bauman. And we have our vice chairs that can also help brainstorm this process.
Thank you.
Thanks so much for that talk. I'm wondering what your personal adventures may or may not have been with working with UW Health compliance and that intersection with clinical research. I feel like when I was starting, that was not a big issue, but as the two systems have become more integrated, which is good, sometimes what the health sciences IRB expects is very different from what they want on the UW Health side. I just wonder if you've had any, a lot of that has to do with data management, data sharing, rather than human subjects issues. I wonder if you've had any experience there.
Boy, there's so much packed into that question. Tell me more about what you're thinking in terms of the compliance side.
So the issue I'm having is actually not I'm a mentor I'm mentoring someone on a K award who has a very specific de-identified route of collecting human subjects data retrospectively. And I think is very safe. The way it's being stored is totally perfect. The IRB is happy, and UW Health does not like that initials are part of it.
Yeah.
And it's part that the reason for that, I'm not going to remember the granular details of this particular piece of the study, but the initials are important because it's a qualitative data collection that you have to be able to, the subject has to be re-identified at different time points and linked to something, but the initials super freak them out. That's one example.
Yeah. I mentioned that the institution is moving in the right direction, and the analogy I would make is like moving an iceberg or a glacier. It takes time. UW Health, as you probably experienced, is very risk averse and is really clamped down in terms of data sharing. You know, there are many people who are trying to chip away at that to get, you know, easier access. I think when Dr. Matthew enables the cloud-based data service, that will help a lot. We're not quite there yet from what I understand, but we're getting close. And the other piece, because of that, you know, risk averse clamp down nature, UW Health has just in the last few years restricted coordinator access to the electronic medical record unless the patient has already signed a consent form. And so if you're screening with coordinators, you have to go through, you know, an approved, you know.
It's been a huge issue also.
It
I
is.
wasn't even gonna bring that up.
Yeah.
But that is another problem because we used to screen our clinic list routinely.
Right,
and now
right.
we can't.
Absolutely. There are ways to do that, and I would encourage you to reach out to the clinical research data service within the ICTR group, because they can build like best practice alerts or workbench tools that will sort of do some of that work for you to identify which patients are coming in clinic today, but they're not perfect. And I you know, the funny story about me, and I'm in storytelling mode now because we have a little bit of time. You know, when I was a trainee, I thought asthma was boring, and I wanted to study sepsis in the ICU. But I studied asthma because of the infrastructure and the ability to learn about clinical trials in a pace that was much faster for my learning and my career development. I just had the opportunity to be a PI for a sepsis and lung injury trial in the ICU. And this policy of restricted coordinator access completely shut me out. I got closed down as a site. It was humbling. So I know there are lots of people who are really you know, working on this, and I know, you know, Betsy Nugent and Nastia Safdar are working on this too, but it's a little challenging still. I would again remind you to work with the data management teams at ICTR, because they can get you lists and tools to do it. But thank you, Lauren. That was informative. I would love to participate and learn more about clinical trials. Would there be needs for a computational biology data science machine? Yes, yeah, absolutely. Where data science might be hugely impactful, so there's this concept of pragmatic trials, which are much, you know, simpler, you know, study questions, so to speak, and that really are similar to comparative efficacy, where you're comparing one clinical practice to another, but you're using big data, you know, from networks of hospitals and things like that to answer those questions. And often these types of trials can be done without patient level consent. It's really, you know, institutional consent of comparing one practice at one institution to another practice, so at a different institution. So I don't know a lot of the details of that because it's come online well after my training. But yes, I think the short answer is data science and machine learning for analysis is the wave of the future for clinical trials. Thank you for having me. Yeah.